A very good evening, everyone, and a very warm welcome to all the delegates and faculty members for No Thrombosis program. And this is the program when we have received the most engaging scientific platform from the SIMS Excellence Award. So we have almost from last 1.5 year we have completed 189 events of no thrombosis. So today we are very glad that with us today we have very eminent faculty with us for today's no thrombosis program. And no thrombosis program is all about the real life challenging cases of clinical and cardiology cases, particularly related to the patients with CAD, PAD, DVT, pulmonary embolism, atrial fibrillation, and COVID-19 coagulopathy. So today's our chairperson is Dr. None other than the well-known recognized Dr. Rajneesh Malhotra sir. Sir, he is the principal director and head of CTVS Cardiology and Vascular Surgery in Max Delhi and Emcure Hospital, Max Institute of Heart and Vascular Science. So from behalf of Emcure, I welcome to Dr. Rajneesh Malhotra sir for our program. And our today's moderator, Dr. Vivek Pratap Singh, is a senior consultant interventional cardiologist from Fortis Scott Heart Institute, New Delhi. And Dr. Kapil Gupta sir, he is also a principal consultant and in charge of Department of Vascular and Endovascular Surgery, trained in endovascular intervention in US, Germany, Italy, Australia, and France. So once again, from behalf of Emcure, I want to welcome to Dr. Vivek and Dr. Kapil Gupta sir for the program. And our today's first speaker is Dr. Kavita Tyagi. Dr. Kavita Tyagi is a consultant cardiologist from Dharamvira Heart Center, and also Dr. Kavita Tyagi is working in Sri Gangaram Hospital, Delhi. And our second speaker is Dr. Ranjan Modi. He is associate consultant and interventional cardiologist from Indraprastha Apollo Hospital, New Delhi. Welcome, sir. Welcome for the program. And our third speaker is Dr. Ashish Jai Kishan. Sir, he is consultant cardiologist from Fortis Scott Heart Institute, Oakland, New Delhi. Welcome, sir. Welcome to our today's no thrombosis program. So today's no thrombosis program, this is the agenda we have, and followed by now I'll not take much more time. I will directly hand over the sessions to Dr. Rajneesh Malhotra sir for their opening remarks. Thank you, sir, and welcome to the program. And hand over to you, sir. Thank you, sir.
Hello. Thank you, Mr. Ravi, and welcome everyone. And I think today we have got a very good faculty. I have got my colleague, Dr. Kapil Gupta, who is a vascular surgeon. Hi, Kapil. And Dr. Vivek Pratap Singh, and three eminent cardiologists who are there.
Good evening, sir.
Hi, good evening. So basically, I would say anticoagulation or no thrombosis, which has got a new interest now, and Emcure has really taken a good initiative in starting this program. And in this series, this is one of the one program today evening. So I think the wide spectrum of healthcare workers or healthcare doctors or providers are involved. Means like you can see that today's, I would say the faculty itself. I'm a cardiac surgeon, Dr. Kapil is vascular surgeon, then we have interventional cardiologists and other cardiologists. So all of us are using anticoagulation in some form or another. And so the spectrum is very wide, and I would say the disease profile is also very wide. It is being used for deep vein thrombosis, it is used for vascular surgeries, it is used for cardiac surgeries, it is used for atrial fibrillation, and it is being used by our intervention cardiologists post-interventions also. So anticoagulation today's date and time has become very, very important. And one more person who uses it I would say very frequently are the neurologists and neurosurgeons. So the spectrum is very wide, and the wide range of people are using from vascular to neuro to cardiac surgeon and cardiologist. And as we all understand, this is one of the life-saving things which and without the anticoagulation or without no thrombosis, we cannot do any of the procedures, and our outcomes will definitely suffer and will not have the desired results as we want. Today we have Dr. Kapil Gupta and Dr. Vivek Pratap Singh who are going to work, who are going to be the moderator for today's session. So I would say I will hand over to them and tell them to take it forward and introduce our speakers and moderate the session. So to Dr. Kapil and Dr. Vivek, please take over the session and and then I will join you after some time once we have the discussion.
Very good evening, sir. First of all, thank
Hi,
you for
sir.
inviting me, and very good to see you. And we really appreciate that you're still working near your office.
Yeah.
You must be having
I
a
just
long
came
day.
out of the operation theater. I did a pulmonary endarterectomy right away, and I just
Okay. Okay. Okay, so very good to see you. So I think we can start the session straight away, right? The first speaker will be Dr. Kavita.
So, sir, Dr.
I think Dr.
Kavita will be
Kavita is
late.
not here.
Yeah, Ashish,
Okay.
Dr. Ashish, we can start. Sir.
Okay. Okay, Dr. Ashish, and we can start with you and so you can please go ahead with the talk.
Sure. Good evening, everybody, and thank you for this platform where I'm going to talk about the vascular dose in coronary artery disease with peripheral artery disease. Is my screen visible?
Yes.
Okay, I'm just making it in the slide share mode. I hope it's still visible. And without much further ado, I'll carry on. So I'm going to talk about the vascular dose and how we have come to this particular vascular dose, specifically talking about the COMPASS trial. And we are talking about a patient in which coronary artery disease with peripheral artery disease, we're going to see about it. We had a gentleman who was a 61-year-old gentleman who had come with complaints of angina on exertion. The classification, CSS classification was class 2. He also had a history of claudication since last 1 year. With the past history of being diabetic and hypertensive, he had underwent multiple stenting procedures. The stent first, which was done to LED 12 years ago, following which 10 years back, he underwent a bypass procedure. And after that, there were 2 grafts which were being placed at that particular time, following which he underwent a plasty to RCA 3 years ago. Now he has presented with a history of claudication since last 1 year with diffuse erythematous disease in bilateral lower limbs. On investigation, we found that his ECG showed that he had normal sinus rhythm with LVH changes. On echocardiogram, he had mild LV dysfunction with a regional wall motion abnormality documented in inferior wall. Bilateral diffuse artery disease was being documented in ATA as well as PTA, that is anteriotibial and posterior tibial arteries. And on coronary angiogram that was being performed, it revealed that patient had a patent graft, which was from Lima to LAD, as well as a venous graft, which was to PDA. Both of these were being patent, with a total occlusion in LAD and RCA arteries that was being documented, and a mild disease in LCX. So his angina, which was attributed to probably class 2 angina, we titrated his nitrates, and from the coronary perspective, he was absolutely fine. When we talk about his claudication, the disease which was being documented was in the ATA and the PTA, that was definitely there. So the final diagnosis was coronary artery disease with TVD with patent grafts and a peripheral artery disease with diffuse diseases that he had been showing in both the artery on both the limbs. He was being discharged on these following medications, which was aspirin 75 milligrams once a day and rivaroxaban 2.5 milligrams twice a day. I'm going to specifically talk about why we have come to this kind of combination, and that's my presentation, which we're going to talk about, and the reason why we are talking about this particular dosage. Rest of the statins, beta blockers, ACE inhibitors, and diabetic medications that he was already on, we continue with the same. Now, what we have seen in our study, that patients who already have a coronary artery disease, they tend to remain at a very high ischemic event rates. REACH registry was a 4-year outcomes registry in which nearly 65,000 patients were being enrolled, those who were beyond 45 years old. And what you can see is that compared to patients who only had just risk factors, the risk factor patients had a risk outcome of CV death or MI being 9.1. vis-a-vis those who had prior ischemic events. Now, the prior ischemic events, if it was beyond 1 year, was around 17.2 ischemic event rates. That is for the CV death as well as stroke at the end of 4 years. But this definitely was significantly higher on the area where the ischemic event rate that had already occurred was less than 1 year. So the REACH registry did show us that even if we capture these patients who had ischemic events in less than 1 year before they came to us, they are having a very high risk for CV death as well as stroke. Now, current medical vascular protection comprises of 4 different pillars. Before we talk about those 4 pillars, we all need to know that the lifestyle modification that we can bring around in our patients is also having a great significance, which includes healthy diet, physical activity, being exercise, smoking cessation, weight control, as well as psychosocial support. Now, the 4 pillars that I'm talking about, these are the 4 pillars. We need to have a good lipid lowering agents that could be statins, ezetimibe, PCSK9 inhibitors. we need to also address the blood pressure control by which we can do with ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics. Sugar control is definitely being taken care by either insulin or OHAs. And finally, when we talk about antithrombotic protection, we all know that DAP or aspirin, that is dual antiplatelet therapy or aspirin, they have a very important role. So these are the standard therapeutic pillars by which we ensure that we are giving our vascular a good protection. But is there any scope for improvement based on this current regimen? Well, for that very reason, we need to understand the coagulation pathway. Of the coagulation pathway, the tissue factor and factor 7A, activated factor 7A, which initiates this pathway, factor 10A inhibitor is the most important way where we can control. Other than apixaban, rivaroxaban is the second drug which prevents or inhibits factor 10A. Dabigatran is a direct thrombin inhibitor. That's another way which we can address the coagulation pathway, but we are talking about specifically rivaroxaban over here. So when we talk about this particular chart in Circulation 2020, we have this particular chart. Don't get confused and don't get overwhelmed with what we are talking about in this cluttered chart, but I need to drive your attention to this particular aspect on your left hand. If a patient who is already having a stable CAD and is only on aspirin, remember, if the past history of multivessel CAD was being done, which was being addressed beyond 1 year or less than 20 years, in that situation, check whether additional risk factors are there, which could include diabetes, asymptomatic peripheral artery disease, CKD, history of heart failure, non-lacular ischemic stroke that has occurred beyond 1 month. In that scenario, then you really need to address if there are any other risk factors in which the patient could have major bleed event or a past history of spontaneous bleed or history of anemia. If these are not present, if the patient is not having any intravascular abnormalities, no history of neoplasm, extreme old age, or frailty. In these scenarios, if you can rule out all these scenarios, in that situation, Circulation 2020 came out with this particular chart. It states that in such indication, not only just aspirin, you need to introduce rivaroxaban at a dose of 2.5 milligrams twice a day. How did we come to this particular aspect? Well, we have been coming to this aspect by COMPASS trial. I'm going to talk about the next coming slides. But presently in 2019, the latest guidelines which comes out and says that the second antithrombotic agent has to be introduced in selected patients. The word over here, underlying factor, is it's selected patients, especially in those patients who are having chronic coronary syndromes. Now, when we talk about selected factors, these selected patients are those who are having high ischemic event rates. In that scenario, you need to address and you need to give your second antithrombotic agent. When we talk about high-risk patients, high-risk ischemic events where the chances are quite high, the class indication is only 2A. But this is the crux over here. If these patients have moderately increased risk of ischemic events, in that scenario, the class 2A becomes class 2B. So you have to give your second thrombotic agents only in those patients who have a high risk of ischemic events. They have specifically defined which are these scenarios where high risk ischemic events are being defined as those patients who are having diffused multivessel CAD with at least one of these followings. They are diabetes mellitus, recurrent MI, peripheral artery disease, CKD, where your eGFR is above 15 and till 60. It should not be less than 15. If it is less than 15, rivaroxaban is not indicated in that scenario. So that's the cutoff, the reason why we say eGFR should be above 15. So these are those patients that have been defined as having high ischemic risk event rate candidates. And in these scenarios, in this particular scenario, the need for the second antithrombotic agent becomes class 2A. On the other hand, if you have moderately risk patients, and that has been defined as one of the followings, that has those patients who are having multivessel or a diffuse disease, diabetes, recurrent MI, PAD, heart failure, and CKD, in that scenario, it becomes class 2B. So we all know that class 2B is something which might be harmful to the patients. So in that scenario, it's better not to go over there. Just we have to understand those patients, those who are having chronic coronary syndromes, having one of these factors beyond diffuse multivessel disease. In that scenario, it becomes giving a second agent as class 2A indication. Now we talk about dual pathway inhibition, but this is important that you need to understand is the first acute phase, that is within the first year period at the very event. You have to understand that that scenario, with that particular situation, it is the dual antiplatelet therapy that takes an upper hand, because at that particular moment it's the platelet activation which brings around the major crux changes in the patient's coronary syndrome scenario. So you need to inhibit that. And for that very reason, dual antiplatelet therapy helps us on that scenario. When we go on beyond this particular 1 year path, we come to the second year onwards. In that scenario, you generally understand that we have been giving single antiplatelet therapy. Now we talk about giving a dual pathway inhibition, where the prolonged thrombin generation which comes into play, you're trying to inhibit it. And for that very reason, you try to introduce your anticoagulants. And that situation, the second anticoagulation therapy is being introduced, which is over and above your antiplatelet, that is aspirin that you've already given. So this is the reason why we need to introduce your antithrombin agents, and rivaroxaban takes an upper hand. And when we talk about COMPASS trial, as we just talked about briefly in the previous slides, that the reason why we're talking about rivaroxaban being 2.5, it is because COMPASS trial came out with that particular dose. COMPASS trial has been also compared, but there has been no direct comparison where the patient was already on clopidogrel or clopidogrel plus aspirin or ticagrelor, which was being used in both the dose, that is 90 milligrams and 60 milligrams in the trials of Capri, Charisma, and Pegasus respectively. In all these four scenarios where the previous trials have shown, the largest amount of MACE events that have been reduced was with COMPASS trial, where it was reduced by 24%, CV death was reduced by 22%, stroke was reduced by 42%, and MI was reduced by nearly 14%. So this is a very important thing where there was no direct comparison, but still the MACE events to strokes to MI and as well as CV death definitely showed a significant reduction in scenarios where ecosprin was being added over and above with rivaroxaban. So based on the COMPASS inclusion trial, these are the following categories that you need to understand that where you introduce rivaroxaban to your patients. In the patients who are having coronary artery disease, if the previous MI had occurred within the last 20 years, patient has had multi-vessel disease with symptoms or stable or unstable angina, where the patient's coronary arteries were being addressed by either with PCI or CABG, and it has to be multi-vessels. Along with that, if the age is beyond 65, or if the age is less than 65, two other additional risk factors have been involved, which includes smoking, diabetes, eGFR, which is being less than 60, heart failure, or non-lacunar ischemic stroke, which has already occurred 1 month prior. So that is the criteria where those patients who have been enrolled with coronary artery disease. As far as the peripheral artery disease patients, those who have been included in this trial were those who had underwent previous revascularization or underwent amputation for peripheral artery disease, had history of intermittent claudication with one or more following criteria that has been met, that is ankle arm index less than 0.9, significant peripheral artery stenosis that has been documented by peripheral angiogram or ultrasonography, previous carotid revasc where it was being documented, or patient has an asymptomatic carotid artery stenosis that is above 50, again documented by peripheral angiogram or by ultrasonography. And finally, if the patient already has a coronary artery disease with a low ABI, which has been documented as less than 0.9. So these were the inclusion criteria that had to be met before the patient were being enrolled in the COMPASS trial. With nearly 27,000 patients that were being enrolled, they were being randomized, placebo-controlled, and double-blinded, where the dose that was being prescribed was rivaroxaban 2.5 twice a day, vis-a-vis with rivaroxaban 5 milligrams twice a day, and with aspirin alone 100 milligrams. So 2.5 rivaroxaban was given with 100 milligrams, and aspirin alone 100 milligrams, and rivaroxaban 5 milligram twice a day. With a follow-up of nearly 2 years, COMPASS was the first trial where NOAC was being used over and above a single antiplatelet, and it definitely showed a reduction in MACE event rates with patients who are having a stable atherosclerotic disease. The primary endpoint, which was CV death, stroke, or MI, definitely, as we just talked about in the previous slide, showed that the MACE event being less by 24% and mortality reduction less by 18%. But there was no significant benefit where rivaroxaban was being given alone. So that was another reason why rivaroxaban with ecosprin had an upper hand vis-a-vis the patients, those who were on ecosprin alone, that is 100 milligrams a day only. When we talk about the selected outcomes, the primary outcomes, the secondary outcomes did not show any significant difference because the P significance that we need to see is that it should be less than 0.005. The P significance was not met in the peripheral artery disease cohort, where it was less than 0.01 in the patients, those who were with rivaroxaban 5 milligrams twice a day. But this significance was definitely been documented in those patients who were having rivaroxaban 2.5 plus aspirin. So this is an important aspect where your significance value with just plain rivaroxaban was not being met either in primary or secondary outcomes, both on ischemic event rates as well as all type strokes. But we definitely had patients who were on rivaroxaban 2.5 with ecosprin, the significant difference where you were giving on this benefit to your patients. So what the clinical implications of COMPASS trial eventually came out that you can switch your patients from dual antiplatelet therapy to dual pathway therapy, where a single antiplatelet and a NOAC has been introduced, specifically rivaroxaban and aspirin. And this therapeutic use of using both these drugs has been shown to be beneficial in patients who are having both coronary as well as peripheral artery disease. At present, by 2019, the NICE guidelines has recommended using of rivaroxaban with ecosprin as an option for preventing atherothrombotic events, especially in patients who are having coronary artery disease or symptomatic peripheral artery disease, and over and above who are having a high risk of ischemic event rates. As I talked about in the previous slide, it has to be high risk of ischemic events vis-a-vis those patients who are having moderate risk, because in moderate risk, it is class 2B indication, and vis-a-vis when we talk about high risk, it is class 2A indication. So rivaroxaban 2.5 twice a day plus ecosprin 100 milligrams definitely helps the patient out, especially after 1 year of PCI. If the patient has already taken a dual antiplatelet therapy, multi-vessel PCI has been performed. In that scenario, this is the combination, and that has helped us out. And that is the reason why you saw the prescription of the patient, which we were just talked about, why the patient had 2.5 twice a day rivaroxaban with 100 milligrams of ecosprin. With that, I would like to thank you all. Thanks.
Dr. Kapil, you have muted yourself. I think you have to unmute yourself.
Sorry, sir. Sorry, I didn't see that. So, first of all, thank you, Dr. Ashish, for this wonderful talk. And it was quite comprehensive talk. And this topic is close to my heart, the role of rivaroxaban in arterial cases. We have been using in venous cases for quite a while now, more than 10 years now. But now recently, after COMPASS trial, it is used in arterial cases also. It has and you explain the rationale for use very nicely. Actually, it came from the coronary section. It was after Atlas 2 trial, which shows the role of low dose rivaroxaban, 2.5 mg twice a day, along with aspirin, also reduces MACE in CAD patients. Then it was thought that why not in peripheral artery disease patients, and then this trial was conducted. So, and yes, in addition to MACE, it also showed a significant more than 45% reduction in MALE also, so which is major adverse limb events in addition to major adverse cardiac events. So this trial was a landmark trial, and now, as you rightly told, the high-risk patients are given rivaroxaban as a dual pathway inhibition in addition to antiplatelets alone. So, only thing that which needs to I can add is that also there is a high risk of bleeding, which also should be taken care. Any patients, the risk profile has to be done, and the patient who already have high risk of bleeding, they should not be added rivaroxaban. It has been shown that the hazard ratio is 1.6. I don't think after this COMPASS trial, then there was a Voyager trial. So while COMPASS trial, it included only asymptomatic patients or were stable PAD patients. And Voyager trial, the patients who had underwent recently interventions, surgery or bypass were included. And even in those category patients, addition of rivaroxaban in vascular doses shown to greatly reduce MACE and MALE. So any more comments from Dr. Vivod?
What I would just, Dr. Kapil, I would like to just add one thing. As you had been also practicing here in Max, and And this is very common for us to operate in a patient who has got a peripheral vascular disease as well as the coronary artery disease. And that happens very often. And
Absolutely.
those patients are really at high risk. I mean, it's a like everyday practice for us, like peripheral vascular disease and coronary artery disease. Either they undergo a PDCA or they undergo a CABG. And for us, I mean, it becomes really, I mean, I would say challenging that what thing to be done first. And whichever way we do it, whether we treat the peripheral vascular or coronary artery disease, these patients are at high risk and they have to be treated like that. And we have to give them a dual pathway therapy so that, I mean, they are protected from the adverse effect in both the ways. I mean, and this, I mean, it's not like that. I mean, this you will see once in a while. I mean, this is we see every single day. So we have to be really, I mean, careful, start dual pathway therapy. And as you very rightly said, the risk of bleeding increases. So we have to be careful about it. We have to monitor the hemoglobin and coagulation profile and everything very regularly.
Correctly said, sir.
Yeah.
Dr. Vibhuti can come in.
Oh, yeah. So I think excellent.
Dr. Vibhuti, you have to rotate yourself. I think your picture is coming a little rotated to us.
You need to rotate.
So,
yeah,
sir, let me rotate. Okay.
Yeah,
now I'm in
you're
your access.
straight.
Okay. So I think a nice presentation by Ashish really has put down the points in a real lucid way. Dual pathway inhibition is the newer buzzword in cardiology. In the patient of chronic coronary syndrome, it has been stress to add another agent along with our routine antiplatelet. High risk patients, definitely the addition of NOAC is an important way in that direction. Rivaroxaban, we should also look the thing that out of all the three NOACs, dabigatran, apixaban, and rivaroxaban, the rivaroxaban has also been shown in the trials to have a cardiovascular benefit over the vis-a-vis other NOACs. Adding a low dose 2.5 BD is a real nice way in that direction. Ashish, would you like to comment what exactly you mean by high risk?
So what I basically spoke about in the high risk specifically is that you need to understand that there are scenarios where COMPASS trial basically told about which drugs patients who have already having a history of CAD, that is multivessel CAD, one of these should be present. Multivessel CAD with diabetes, at least it should be present, or patient had a recurrent MI, or patient has had a peripheral arterial disease being documented, or a patient has had CKD with eGFR ranging between 15 to 60. So that has been the 4 points over and above multivessel CAD. So these are the specific patients. If they are the ones who comes into your clinic, they should be prescribed dual pathway inhibition.
Correctly. And if we see across of the clinical spectrum, the patient which we routinely face day to day, definitely, generally, most of the patients fall into this category. And so important message by Ashish. Thanks, Ashish.
Most welcome, sir.
I think we can go ahead and Dr. Ranjan Modi will be giving us a talk about complex DVTs.
Yes. So let me, good evening, everyone. So let me just start my slides. Give me 1 minute. Okay, so I hope my slides are visible. I'm just going to. Good evening, everyone. Good evening, Dr. Kapil. Good evening, Dr. Rajneesh. Good evening, Dr. Vibhuti. Hi, Ashish. We're going to talk about recurrent DVTs according to the case scenario. Now, this is one area which we've been still following the ACCP guidelines. We're still looking at how long to give, how long not to give. This is one of the areas we've still been confused about 3 months, 6 months. How do we work about it? So I'm just going to talk about it. And, I would really want everyone to join in because I'm sure Dr. Kapil and Dr. Ajish have given a lot of insight about how to work regarding this. Now, we all know that patients with DVT are at high risk of pulmonary embolism. 90% of the pulmonary embolisms are results of DVTs. 82% of acute pulmonary embolism have detectable DVTs at the time of pulmonary embolism is diagnosed. We always end up finding, clots in the venous Doppler system when we get it done. So, yes, DVT is a big problem, specifically provoked, unprovoked DVTs. Now, let's look at a case-based scenario. Now, there are patients who are greater risks of VT occurrence. As we said, there is unprovoked VT. Now, this is a patient, 68-year-old male, has an index episode of proximal DVT of the left eye 3 weeks ago, and we've not been able to identify the cause, except his obesity and maybe. This is what we call unprovoked VT. It's a provoked VT when the patient is a 68-year-old female, moderate renal impairment, recent VTs, and it's a provoked VTV also when it's a 47-year-old male who's 220 kgs of weight and is a frequent flyer, and for more than 3,000 miles, he's been sitting on the seater more than 8 hours a day. So he develops some pain and swelling and develops a VT. Now, in all these, the question becomes, is provoked VTs usually what we're dividing nowadays is because of cancers, because of surgeries, and because of other minor ailments like females on hormonal therapies, people who are on long flights. So now it has not just come to unprovoked and provoked DVTs. Now the provoked DVTs also has got divided into various categories depending on the percentage of risk which it takes place at 1 year and at 5 years. So when we saw this, it's a provoked VT with risk factors not related to surgery and trauma. Now, in such patients, a provoked VT, patients with persistent risk factors have almost 1 in 10% chances of risk of reoccurrence in 1 year. If we look at provoked DVTs, cancer has the maximum. It has about 20% more chances of recurrent VTs at the end of 1 year. When we look at surgical causes of provoked VTs, the risk of recurrence comes to about 1% in the first year and about 3% by the time of 5 years. And when we look at the other factors of provoked DVT, except surgery and except cancer, it comes to about 5% at 1 year and 15% by the end of 3 years. So we know it's just not divided into unprovoked and provoked and making it simpler. It's actually got more complicated for the fact that the percentage of recurrence and risk of recurrence of VTs has gone up at 1 year and at 5 years in all these different reasons or etiologies of provoked VTs. So as we said, 1 in 10 years risk at 1 year. When we look at provoked VTs, again, transient risk factors can result in 1 in 14 at the risk of 1 year. Now, these are risk factors who are travelers, as I said. So these are patients who at 1 year have a 5% risk of recurrence of VT, and at 5 years have a 15% risk of recurrence of VT. Now, there were 2 big trials, which was the Einstein Extended, Einstein Choice. Einstein said, let's treat till about 12 months. So up to 3 weeks, then up to 6 months, and then finally went up to 7 to 24 months. And rivaroxaban had given evidence from acute to extended VT treatments almost up to 24 months. So that's what the extended treatment showed us. Now, when we look at this graph, we'll be able to, when we look at this graph, it shows that rivaroxaban showed consistent efficacy from acute to extended treatment of VT. Now, during the Einstein P and the Einstein DVT trial, the Einstein Extension and the Einstein Choice, we were able to reduce the rates of recurrence of VTs with rivaroxaban 20 milligrams once a day, and even with rivaroxaban 10 milligrams once a day by a significant margin. There was an 82% relative risk reduction when we looked at rivaroxaban 20 milligrams OD during the Einstein Extension trial. And when we compared it with even VKs or enoxaparin, there was a 70% relative risk reduction, and these values were significant. So that at least showed that rivaroxaban is the drug of choice for extended treatment or even in acute treatment or the index treatment of VTs. Now, it also proved a reassuring safety profile when we looked at acute and extended treatment. So when we start looking at major bleeding, we all thought that initially that all these NOACs are going to cause a lot of bleeding when we extended treatment of VTs are given. But 99% of the patients did not experience any major bleeding with rivaroxaban in the Einstein program. So we went across the spectrum from 10 milligrams to 15 to 20 milligrams. We were able to see that in the entire spectrum of change in doses of rivaroxaban, there was no major increase in rate of bleeding. It was not a significant increase in major bleeding in all these programs. Now, coming back to the question which I initially raised, now who receives this extended duration of treatment and how long? Now, this has been quite a big topic of debate on who receives this treatment and how long should it take a treatment. Now, we all know that the index event, we need to start rivaroxaban at 15 milligrams twice a day for 21 days and then shift to about 20 milligrams for 3 months. Now, the question arises now, what after 3 months? Should we really extend indefinitely, really extend to 6 months or 12 months? A lot of literature on this has said that there have been multiple risk factors which need to be taken care of. If the patient has a provoked surgical DVT because of a surgical risk, its risk at 1 year is very, very low. You can get 3 months of treatment. You can stop treatment because even at 5 years, the risk is only 3% of a reoccurrence. So you stop at 3 months. You reassess the patient. If the patient has reasons like cancers of provoked DVT, then you can extend the treatment. Even during extension of treatment, it is said that male patients are more likely to have recurrence of DVT compared to females. And even D-dimers, which are raised at the end of 1 month and 6 months, should actually be continued with treatment. So again, this question, I'm going to keep it there, that at the end of 3 months with a patient of provoked surgical provoked VTE, should we continue after 3 months or should we stop? A person who's a frequent traveler, again, we diagnosed a patient with DVT. We gave the patient 3 months of anticoagulation with rivaroxaban. Again, the same dose of 20 milligrams. We continue. We advise them to stop, lose weight, reduce long distance flights. When should we stop the treatment? Should it be 3 months? Should it be 6 months? As we look at the risk factors, there's a 5% risk of recurrence at 1 year. There's a 15% recurrence at 5 years. So should a patient who's a non-surgical provoked DVT, should he be continued for 6 months? Should be continued indefinitely or 3 months is again a question. If you look at unprovoked VTs have a very high risk factor. We saw a patient who had unprovoked VT, which was one of our cases. So the patient was started on 15 milligrams twice a day for 21 days. So should we continue again with 20 milligrams once a day indefinitely? Or should we stop? Or should we wait for 3 months, repeat his D-dimers, and have an idea on what is the reason? Most of the literature has said that unprovoked VTs have a high risk. The risk is almost about 10% of recurrence at 1 year and 30% at 5 years. So the ACCP guidelines still say you can continue your treatment as long as needed. So this 3 months, 6 months indefinite treatment is again a very individualized approach. There have been a few factors like males, like oral hormonal therapies, looking at D-dimers, looking at other risk factors, looking at the reasons of bleeding risks and the risk of recurrence of DVT. If the patient has a higher bleeding risk, then yes, after 3 months, we can stop the treatment. So it has to be an individual risk assessment once we are able to confirm and once we've given from the index event, the acute treatment of DVT which has taken place. It has to be individual risk assessment to look for additional comorbidities which are supposed to be there and look for how long the extended prevention should go. So this is a flowchart which I actually found on when I was trying to go through this and trying to understand how long. It said that treat for 3 months and reassess. If it's an isolated distal DVT, we stop at 3 months because the chances are lower, the risk of recurrence is lower. If it's a reversible provoking factor, we stop at 3 months. If it's an unprovoked proximal DVT or a DVT which has caused a pulmonary embolism, then we look at the bleeding risks. we prefer to stop. If the D-dimer was positive, we stop at 3 months. If the D-dimer was not positive, we stop and measure the D-dimer after 1 month. Now, if there is a high bleeding risk and if the patient prefers to stay, even if the D-dimer was negative, we do give indefinite treatment. So, unprovoked proximal DVT, not a high bleeding risk, and we can continue with indefinite treatment. If the patient has suffered a recurrence of DVT, then yes, we have no choice, indefinite treatment. If we are looking at an unprovoked DVT and we're looking at D-dimer after 1 month, if it's a negative D-dimer, we stop at 3 months and forget it. If it's a positive D-dimer, we restart therapy and continue it for indefinite therapy. Now, it again, as we spoke, sex makes a big difference. Males would even stop if the recurrence risk is at 16% in the first year, but females would stop even if the risk factor is about 10% in the first year. Now, this change in the sex between males and females does make a big difference. So after all this, what I would say is cancers, recurrent VTs, we need to continue the patient on indefinite therapy. If the patient has an unprovoked proximal DVT, and if the patient's D-dimers are positive, we need to continue the patient on indefinite therapy. If the patient had a negative D-dimer, we can stop at 3 months. If the patient bleeding risk is high, we stop at 3 months. Isolated distal DVT, we stop at 3 months. And if we find reversible factors like just because of surgery, we can even stop at 3 months. So this is what I could understand of this entire thing. Now I would really want Dr. Kapil and everyone to please join in and please give us an idea of what's their take on this topic.
Well, thank you, Ranjan. That was a wonderful talk, and you covered this topic quite comprehensively and discussed all the aspects of surgical provoked, well, any other reason for provoked DVT and unprovoked DVT, and the rationale for treatment, 3 months, 6 months reduction treatment. So, well, I think the worldwide recognition for DVT has arisen after COVID, and now many people are quite accustomed to use NOACs. Earlier, only low heparins were used, but now with COVID, I think NOACs have taken the good leap. So, I'll agree with you what you have discussed, that for a surgically provoked DVT, I'll give treatment for 3 months only. For a case of a provoked DVT, for unprovoked DVT, I like to give treatment for 6 months normally, and then I stop treatment after 6 months.
Okay.
If the patient develop a recurrence, then only I go for an indefinite treatment. I generally do not get any thrombophilia workup done because I don't think they are cost effective in that sense, because treatment doesn't change either way. So, an advantage with rivaroxaban has always been that there is no need for adding low molar heparins before the start of therapy. You can straight away start with rivaroxaban. Similar is with apixaban. So, yes, these are very good drugs and quite time tested. And now I'm regularly using NOACs only. I'm not giving low molar heparins. I think the pharma companies are very angry. I'm not using low molar heparins anymore. But yes, I think this is the way to go. Well, if something can be treated easily with medicines without injectables, why not? So, well, I'll 100% agree with you with your presentations, and your I think your ideas were good enough.
I think what I understood from the entire thing when I was going through it was, again, it's a very gray area still lying there. But I think there's always 3 months, and indefinite is where the most of the things lie. And as you said, the thrombophilia profile costs a lot, specifically in Indian conditions. It's a big. So D-dimer, actually, one of the articles said, and it was very useful, that if the D-dimer is still positive after 1 month, then kindly continue if there's no bleeding risk factors. So cancer and unprovoked DVTs who have developed a recurrent DVT or pulmonary embolism, indefinite treatment, that goes off. A distal VT, 3 months goes off. VT because of surgical, 3 months goes off. It's the middle part, 6 months or not 6 months, which is, and again, as Sir said, I think COVID is still one thing which we don't know how long to give. Should we again go through the D-dimers, look at D-dimers, look at the fact that if the D-dimers are high, should be continued for another 3 months or indefinitely? It's again a question which is bothering everyone.
Yes, correct. Well, even in the COVID phase, we found that CRP levels and D-dimer levels are elevated after quite a while. So yes, in those kind of patients, this algorithm will work. Well, although I have not done D-dimers personally to any patients post-operatively, but yes, it makes sense that in case the D-dimer levels are elevated, you can continue therapy for another 3 months.
We actually did a few cases in which we used to check for D-dimers once the patients were back because they had documented VTs during their COVID. And their D-dimers were still high even after about 3 to 4 months. We continued them for 6 months. And because we had no evidence, we did stop their anticoagulation after 6 months. But luckily, we don't have a long period of follow-up as yet. We still don't know after a year, because they just stopped anticoagulation after a year, will they have recurrence VTs or not? But we are hoping that our our common sense works in this aspect.
Maybe Dr. Rajneesh can give his opinion and share his wisdom.
Because I would say same, because the COVID has taught us new things about the NOACs, and I have patients who had their D-dimers are still high after 9 months or 1 year of this thing, and they themselves don't want to stop it. They ask for it, sir. I should continue. Let it continue 2.5 milligram twice daily. I'm having no problem. And I have a patient who is taking for more than a year and he doesn't want to stop it. He will always come and check his D-dimer and CRP, and then he will say that this is the thing and I should continue on that. So that is the thing. I think at NOACs, per se, I would say I have found it to be very safe. I mean, we do not really see as much, bleeding events as we see with the VKAs. So I think NOACs are really pretty safe. And 2.5 milligram twice daily is pretty safe. If you are even giving with aspirin, that's really pretty good, I would say. Yeah, so now we have Dr. Kavita also with us. So Dr. Kavita is also going to, I think, have a presentation and tell us about what she's going to talk to us about. Dr. Kavita?
Thank you, sir.
Nice presentation.
Good evening, sir, and good evening, all of you. Actually, I joined in between. I really didn't understand. I think it was very, very elaborate lecture. But these people told me that any case presentation we have to do. So I brought my routine coronary case only, so that I'll present. Actually, I think, honestly speaking, I didn't know what the theme of this was it. So I'll discuss my coronary case.
So we are discussing about the new generation anticoagulations and about rivaroxaban in various conditions, in various scenarios, and I think you're rightly fitting in. Coronary case was not discussed till now. I think you can use coronary case and highlight the role of rivaroxaban and NOACs in coronary category. If you're alone in the room, you can remove your mask. I think you will feel better after a whole days of hard work. Or still working?
I'm still in hospital.
Okay. All right.
Okay, sir. So we had this patient, a young patient, 30 years old male, smoker and obese with dyslipidemia. And he presented to another hospital with chest pain. ECG was done, which was suggestive of maybe ongoing anterior wall MI, slight ST elevations. Echo was done, which showed LED territory hypokinesia, EF 40%. So he was taken for angiogram. And this was the angiogram, which showed clearly LED osteoproximal thrombotic occlusion. TIMI almost zero flu after that, and other coronaries normal. So patient was already loaded with dual antiplatelets in emergency, and heparin was also given. Now, yeah, RCA is normal. So we took thrombosuction, and we did many runs, in fact, with the thrombosuction. And after many runs of thrombosuction, we started seeing some slight improvement. May not be in this view. We gave lots of NTG, Nicoran, SNP, etc. And yeah, in this view, so we can see that there's some improvement in LED flow. Now, after this improvement in LED flow, the patient had relief from the chest pain. And so we thought that now it is almost 50% of the lumen which we have achieved. The patient is young, so we just revisited our strategy of putting a stat right away. So we gave pyrofiban also, and dual antiplatelet already had given, heparin was also going on. So we discussed with the family also that we can, delay the stenting process. So maybe we will wait for the night entire if patient's family is willing. And we will obviously be on the duty and we can take him up anytime if patient develops chest pain or ST elevations again. So impression after repeated thrombosuction and intracoronary tirofiban loading dose. Post thrombosuction residual stenosis, we could see almost 50% and TME3 almost was achieved. And so we plan to keep patient on IV heparin and dual antiplatelet for the night and to repeat CAG next morning if the night goes smoothly and nothing happens. So we waited for 30 minutes on table before we took out the patient of cath lab, and LED was flowing as seen in previous view. This is the ECG after this thrombosuction. So looks a little better. Now again, next morning, 6 a.m. very early only, I took the patient for angiogram again because of my own apprehension actually. So this was the view. It was as stable as yesterday night. Again, we gave a lot of SNPs, NTGs and like that. So then this was the evolved almost anti-wall MI. Now next angiography we did after 48 hours. And patient was actually loaded with prasugrel when we did angiogram before discussing with patient's attendants when they agreed to do repeated angiograms and possibly imaging if required. So we had already loaded the patient with prasugrel. So patient remained on prasugrel, ecosprin, and heparin infusion with APTT monitoring for complete 48 hours. Patient remained symptomatically stable, and we could manage him for 48 hours without doing anything actively. So we again did his angiogram after 48 hours, and this was it. Stable 50% stenosis as was seen, and flow is seen now actually better. In fact, actually TME3 flow now after 48 hours of angiography. Again, we give a lot of SNP, etc. So now we did this time OCT. We explained to attendants that we will do OCT now imaging. And if we think that we should do stent, then we will stent. Otherwise, we will leave the patient on dual antiplatelets or maybe anticoagulants. So this was the pre-planned PCI OCT run analysis. So we saw a lot of red thrombus. Area was 5.37 in this entire area. And all over the luminal area was 50% of the distal reference vessel diameter. This was the result after OCT. So we again discussed with the family that this is thrombus and 50% lumen is there. Patient is pain-free and TME3 flow has been achieved. So we still can adopt the policy of deferring the stent. And if anything happens anytime, we are ready to. Patient was staying nearby Gangaram Hospital. So the family also agreed and we left the patient. So patient was discharged on rivaroxaban 15 mg OD, ecosprin, and Clavix 75 mg, and atorvastatin 80 mg. So this was angiography after 1 month, and it was as stable as it looked. Patient did not have any symptoms throughout. And again, we repeated the OCT. So thrombus almost was gone. And what we could see, the stable fibrofatty athyroma. So that patient is still stable on those therapy, did not have any symptoms after that. So if we see the erosion steady, effective antithrombotic therapy without stenting, intravascular optic coherence tomography based management on plaque erosion. So they concluded that 1 year follow-up of optical coherence tomography demonstrated a further decrease in thrombus between 1 month and 1 year follow-up. And 92.5% of the patients with ACS with plaque erosion were managed with ecosprin and ticagrelor without stenting, and they remained free of any major adverse cardiac event. for at least less than 1 year. Now, erosion 3 trial, a randomized trial of OCT guided intervention in STEMI patients with early infarct artery patency. So whether OCT guidance compared with angiography guidance only is associated with lower stent rate implantation during primary PCI in the STEMI patients with non-obstructive stenosis. That was their aim to look into. So what they saw was OCT features, plaque rupture in 66% cases, of which 59% were stented versus 41% who were not. And plaque erosion was seen in 29%, of which 14% were stented, 86% were not. And calcified nodules were seen in 5% cases. So this is our day-to-day clinical experience also. And this is the outcome of OCT 3 trials. So the rate of stent implantation in OCT guided group was 43% compared to 58.3%. P was 0.024. And OCT guidance was associated with 15% reduction of stent implantation when compared with angio guidance. Major adverse cardiac events in terms of cardiac death, recurrent MI, TLR, etc. It was similar in both the groups. So now, why we should adopt to such kind of a strategy if it is not feasible in all the cases? Because same night I did another case in which patient had multiple VTs. Another fellow was also equally young and equally almost same clinical profile, but patient developed multiple VTs and the artery was closing again and again. So I had to stent that. But in this case, since patient allowed us, patient gave us the time, the family also understood what we had what our intention was, and the patient was ready to undergo the angiography and OCT, so much expense also, repeated angiographies. So in this case, I could follow up the entire case, but not obviously possible in all the case. And most of the times in primary angioplasty, we have to put a stent also. So if we could avoid this kind of stenting in MI, we know the obvious benefits, the potential advantages and pitfalls of a deferred stenting strategy compared to immediate stenting in patients with high thrombus burden. So deferred stenting, what are the disadvantages? Yes, obviously we know artery might reocclude anytime, and we might end up doing unplanned revascularization any point of the night and increased bleeding from extended parenteral anticoagulation. We kept the patient for 48 hours on heparin, and initially 12, in fact, it was TAPT, and increased medical expenses, obviously, for which everybody will not agree. Problems with immediate stenting, all of us, we say day in and day out, increased slow flow, or maybe sometimes no reflow, increased stent thrombosis. These are, of course, clinically nowadays less because of good stents and good dual antiplatelets. And yes, late stent malposition is a well-seen entity. And in fact, because the entire artery is in spasm, so we tend to put smaller size of stent. That also we had one case recently where we put almost 3.5 stent, but still thrombus was formed. We thought we are enough to go ahead with this stent. But when we did the IVUS, we found that artery was far bigger than 3.5 also. But then that time we could only post dilate. So these are the phenomena we see commonly in primary angioplasties. And smaller stent size we tend to put because of the vasospasm. Sometimes patient's hemodynamics doesn't allow us to give a lot of SNPs and MNPs. The advantages of deferred stenting, no thrombus burden, we get very stable plaque. Obviously, the burden of slow flow or no reflow will be decreased periprocedural MI, improved thrombolysis and MI flow. Slow flow or no reflow will be prevented in many of the cases, not all. And we will be able to put adequate stent size, maybe number of stents less. As we have seen, the spasm is relieved completely. And infarct size may become smaller. So this was my case. Thank you so much.
Nice, Kavita ji.
Yeah, Dr. Kavita, I think that was a really very good case, because most of the things, many times you see a thrombus in the vessel and then the patient becomes unstable. Unfortunately, in your case, the patient remains stable and you could do thrombosuction and start patient on anticoagulation, and we could manage the patient pretty well. So I think that is what we, also face many times. And then you try to put a stent and all, the patient becomes more unstable, and then we land up in bigger trouble, the arrhythmias and revascularization injury and all. So this happens. So I think we open the floor for everybody's discussion. Dr. Kapil, Dr. Vibhuti. So I think everybody should put their.
I think Kavita ji, a nice case. Only thing, one approach would have taken a different. Young patient, less bleeding risk. You can also go for intracoronary thrombolysis, 1/4 of the conventional dose. Wait for 30 minutes, the thrombus burden goes. But definitely, kudos to you. Definitely right way that you waited for the thrombus to clear. Image guidance is definitely a good thing. OCT, I would really make it over the IVUS because of the characterization of the thrombus and the other morphological features. And waiting for the thrombus to clear, again assessing, is a really nice strategy. No doubt about it. Regarding the NOACs, in this case, you had used post procedure. Definitely, as our understanding of the NOAC has been increasing from atrial fibrillation, PCI, peripheral arterial disease, chronic coronary syndrome, it has been going on and on. It's also with the COVID era, the NOACs use has been really a much. So we are more confident, as Ranjan was also pointing out regarding the NOAC in DVT. I think it should be an individualized approach rather than a guideline-based approach. The patient has blood score is low, the bleeding profile is low, he is young. We can definitely think for an indefinite duration of the NOAC. If the patient is having multiple comorbid things, we should be taking on in a different way. So overall, all the nice presentation by 3 speakers, and I will hand over the thing to Dr. Next in the line, Dr. Kapil.
Hi, Dr. Kavita, it was excellent talk and very well done. When we're talking about NOACs, the only thing I found that you use a dose of 15 milligram of rivaroxaban post-operatively. So which regimen are you following? Because 15 milligram, we generally reserve only for DVT in loading doses. So I just want to know about that.
Actually, patient was being given dual antiplatelet also. So sort of, I think, clinical balance we thought of.
Okay. So normally, I think because we are using in a vascular doses 2.5 milligram twice a day.
Yes.
Or we're using. So that was.
Generally, it is a lower dose, Kavita. Definitely in the thrombotic burden, you have used a higher thing. That is okay for that case, but definitely it's a lower dose along with the antiplatelets.
For chronic coronary syndrome.
Yeah, for initially also, sometimes we give loaded doses 15 milligram twice a day when we give given full thrombotic doses. So we start 15 milligram twice a day. So that's fine. That depends upon individual choice. So well done.
I think I will agree to what Dr. Kapil said. Hi, Dr. Kavita, wonderful case. I'm so sorry. I think agree. Low, I'm not very sure. I'm not a very good fan of doing low NOAC doses because at the end of the day, we got to look at how efficacious they are. If we are using low dose NOVACs, then we are not solving. It's like using Apaxaban at 2.5 milligrams for a patient who doesn't fall into any of those 3 categories, 2 out of 3 categories. So we are just using as a placebo. So 15 mg, yes. Again, one of the other questions with this week, how long will you give NOVACs? Is it become a triple antiplatelet therapy? With AF, with PCI, we understand we need triple antitherapy, but in these cases, to give it for 1 month, we give for 15 days. Do we switch over the antiplatelet then to maybe ticagrelor later, or we continue with clopidogrel because we don't have evidence with ticagrelor, and we know PCI is the best with ticagrelor. So these are again questions which are, as you said, very individualized. Dr. Vibhuti said, I will agree. IVUS would have been instead of IVUS, OCT would have been the best imaging here because. We recently had a case, we had total 100% occlusion of the LED. We did an IVUS after 2 days of anticoagulation and we saw that it was actually a myocardial bridge which had a thrombus which had fallen up from the proximal LED into the myocardial bridge, and it was showing 100% occlusion in the mid LED. So if we would have done everything, we would have just sent it the mid LED and come out. And we would have sent it in the myocardial bridge, would have been very wrong on our part. So yes, OCT actually showed that there was a huge dissection flap, there was a huge thrombus which was there, and that's why we ended up. So in this case, OCT would have been able to tell us the thrombus characteristics. Is there, what is the amount of red and white thrombus? Is there, what is the TICFA in the entire thrombotic region? Should we really need to stent it, or can we just wait for anticoagulation and send it back home? So yeah, I think too many questions to think about.
Yes.
I think all the speakers had wonderful talk, and I can.
I think sir is saying something.
Sorry. So, Dr. Modi, I'm sorry, I just wanted to ask you, where do you decide for OCT and where do you decide for IVUS? I mean, you have some specific indication where you're going to do that, or you decide based on the availability, whatever you have?
Yes, the first choice is whatever you have. You can't have both in the same cath lab because then it's too much on the pocket for the hospital and the doctor. But I think it's like an HD TV and a black and white TV, at least what I feel. OCT gives us a lot of information. It's mainly because you become used to using a particular kind of IVUS or OCT, so you become a little more easier to read those things. But OCT tells us a lot of information specifically about thrombus. It tells you immensely where to do, what to do. Is there actually in-stent restenosis? And if it is there actually a smaller stent or a bigger stent? Is it a undersized stent or not? I think except the left main part of it, and then except the CKD part of it, I think OCT is able to solve most of our problems. And I actually feel even in Indians, we have a left mains of 4.5. In those, even OCTs can be done with a left main of 4.5, unlike Western population, which have left mains of 5.5 and 6, where it becomes a big problem. So I think it's just you're easier with one technology what to use.
Yeah. So, Dr. Vibhuti, you want to say something?
Okay. So the thing is that if you want for the correct vessel sizing, IVUS will be the choice. If you are going for left main intervention, IVUS will be the choice. OCT, anything inside the lumen, any vessel size less than 4.5, any patient who has got a creatinine that is in a normal range, OCT will be preferred. But as Ranjan rightly said, it also becomes the operators who is comfortable with what. Ranjan, Ashish, I both are all have got escorts background. We have got a fair OCT exposure. So generally in our labs, if you see, it will be OCT, OCT, and OCT.
We are very much biased to OCTs.
That's what I would say. I mean, even at Max, I will find that they are using OCTs every day. I mean, so wherever, because they have OCT, so they will use it wherever they can.
We love the HD part of it than black and white. So I think it gives us too many colors. So we are happy with the.
It's a beautiful way to explain it, that black and white and LCD TV, that kind of a thing.
I want to look at an LCD.
Everything has to be in color. We are more than happy about it.
Yeah, that's true. So I think we really had a good discussion today, and I think, as I was saying, we have discussed about the whole spectrum of it, from the peripheral vascular disease to intervention to DVT. So the whole of the thing has been covered, and I would say it's like 9 o'clock. We already crossed the time given to us, so we should thank Emcure for this opportunity, and it was really good for all of you to be here in this platform today, and we could have a good interaction today. Thanks, everyone. Thank you very much.
Thank you so much.
Thank you, sir. Thank you so much. I especially want to say thanks to all our Dr. Rajneesh Malhotra sir and our moderator Dr. Kapil sir and Vivek sir. A fantastic discussion. I think this is one of the very unique no thrombosis program we have conducted today, where we have discussed very variety of different cases. And thanks to all our speakers, Dr. Ashish Jaikishan sir, Dr. Ranjan Modi sir, and Dr. Kavita Dagi, fantastic presentation. And we can see the more than 575 doctors have watched the program today. So excellent, and thank you so much for all the faculties. I think before closing today's session, I just want to show 1 minute of video, and then we will close the program. Thank you, sir.
Do you know which Indian pharma company has consistently launched innovative first-in-India products? Presenting Emcure Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Exafib is our brand of rivaroxaban, and it's number one brand in Indian all rivaroxaban generic brands. So that is one of the very good brand and very equivalent to the innovator. So with this, I think we will close today's program. And once again, thank you so much to our Dr. Rajneesh Malhotra sir for hosting this session, and also our moderator and speakers. Thank you, sir. Thank you so much, and good night, sir.
Thank you.
Good night. Good night, sir.
Good night. Bye.